Welcome. My name is Dr. Brian Hill. I'm the director of the Lymphoid Malignancies Program at the Cleveland Clinic, Taussig Cancer Institute. I'm joined today by Dr. Jennifer Woyach, who is the section head of the CLL program at the James Cancer Center at Ohio State University Medical Center, and the co-director of the Leukemia Research Program. So this is abstract 961. This is the efficacy of Pirtobrutinib in covalent BTK inhibitor pre-treatment relapsed refractory CLL, SLL. This is additional patients and extended follow-up for the phase 1, phase 2 Bruton study.
So as you mentioned, this is an updated analysis. It's something I'm sure you guys have talked about many times before with the CLL Society, because it's really an exciting new drug called Pirtobrutinib, which is a very selective reversible inhibitor of BTK or Bruton's tyrosine kinase. So just as a little bit of background rationale, we know that people who relapse on covalent BTK inhibitors often have mutations in BTK that will make the rest of the group of covalent inhibitors not work. Reversible BTK inhibitors can bind to different sites on BTK. And so even in the presence of mutations that confer resistance to drugs like ibrutinib, acalabrutinib, and zanubrutinib, drugs like Pirtobrutinib have the potential to be effective. So this is a very, very large phase 1/2 study, has 276 total patients with CLL and SLL in it now. Here we see quite a bit of updated follow-up, including, I think most importantly, we see the median progression-free survival with this drug being 19.4 months. Of note, this is a really heavily pretreated group of patients, median of 3 prior therapies. As you mentioned, all of them have had covalent BTK inhibitors before. Most of them progressed on those BTK inhibitors. I think about half of them had BCL2 inhibitors, and obviously many others have had chemotherapy and other approaches to treat their disease. So besides the efficacy, which is really exciting, the other really exciting thing about this drug is the safety profile.
Yeah.
So as mentioned, it's a really selective inhibitor, really only targets BTK and very weakly any other targets. And we really don't see a lot of those side effects that we attribute to BTK inhibitors as a class.
Yeah, so I agree that there's a tremendous kind of amount of excitement and anticipation of being able to use this agent more widely. What is your thoughts, as I'm looking at the, the abstract again and looking at the Kaplan-Meier curve? You mentioned, of course, these are really heavily pretreated patients and probably wouldn't have had many good options. So the fact that you can see responses in this group is excellent. On the other hand, the curve is sort of continuing down, whereas with some of the other agents, in earlier lines of therapy with BTK inhibitors, we almost see this plateauing, and it goes on for years and years. What are your thoughts about, what might be happening with after 18 months, you've kind of hit median progression-free survival?
So, we saw from a paper that came out of the Memorial Sloan Kettering group earlier last year that many patients who develop resistance to these non-covalent inhibitors also do so by acquiring BTK mutations, different ones than we see with drugs like ibrutinib and acalabrutinib, maybe similar to what we see with some patients on zanubrutinib. And so, I think the big question is, does this continued kind of resistance acquisition, is that because these are pre-selected patients that already became resistant to another BTK inhibitor and, are more likely to be clonally diverse and, acquiring mutations in general, or is this something that we will see when we're taking more patients who have had less prior therapies? On the phase 1 portion of the study, patients had to have 2 prior therapies, I think. And as the study went along, they tried to enrich for some of the highest risk group of patients, those that had had chemotherapy, BTK inhibitors, BCL2 inhibitors, and even PI3 kinase inhibitors. So you're already kind of self-selecting for a group of patients that can develop mutations pretty easily. Yeah. And my hope is that if we see more patients who are getting this as either their second or third line therapy, either first got a covalent inhibitor and then this, or got venetoclax and a covalent inhibitor, then this, maybe we'll see very much prolonged disease-free survival.
Right. Yeah. Sort of more durability, I guess.
Yeah.
Yeah. Yeah. And what are your thoughts about kind of moving as this hopefully eventually gets, of course, approved, but also moved up in earlier lines of therapy? Are there patients, if you had a patient, sitting in the clinic with you who needed treatment for CLL, are there scenarios where you might consider using this before a traditional covalent BTK inhibitor?
Yeah, I think that's a great question. And we don't have really any data in that setting right now to guide us. I mean, conceptually, I like the idea of first using a covalent inhibitor and then a non-covalent inhibitor if you're going to use them in a continuous fashion, because these mutations that are making people resistant to Pirtobrutinib likely are also going to be cross-resistant with acalabrutinib, zanubrutinib, ibrutinib. The one caveat to that, though, is if you're thinking about a combination approach for like frontline therapy, where you do a year of treatment or something like that, some sort of fixed duration, I think it is absolutely reasonable to consider a drug like Pirtobrutinib just because of the great safety profile. It would be an easy drug to combine with other agents.
Yeah, no, that's a good point. So do we have preclinical data? Because as you point out, the mutations in BTK that confer resistance to Pirtobrutinib have already been, some of them at least, have been defined. And so do we know that those prevent binding of the covalents?
So
in some cases?
Yeah, so the paper that described resistance actually did some work in this and suggesting that that's the case. So, some of the mutations, ones that are in T474, that's a gatekeeper residue. And so those are going to confer resistance to other BTK inhibitors. And actually we see them infrequently, but we do sometimes see them in patients on covalent BTK inhibitors. Some of the other ones like L528W, a few others, are actually kinase dead mutations, which it's still a little bit unclear how exactly those would confer resistance since they don't turn back on BTK and don't seem to prevent binding.
Right.
But likely a mutation like that also is going to make people resistant to a covalent inhibitor. And actually that L528W mutation has been seen in small groups of patients on zanubrutinib too. That was published by that group from Australia last year, I think, too.
Yeah, no, that's interesting to think that the sequencing may matter in terms of you don't want to burn bridges. So if you know that cysteine 481S mutation responds equally well to whether you have it or not, you can still respond to Pirtobrutinib. But the other way around, if the mutations that may arise from Pirtobrutinib may render the covalence ineffective, that does sort of raise the question about the importance of monitoring this and being mindful about it when sequencing.
And I guess the other thing to think about too, when we're thinking about frontline therapy, is when you give a covalent inhibitor to people for frontline treatment as a continuous therapy, most of the progressions that we see, even at later time points, actually are people who come off the drug first and then progress. It's actually pretty uncommon for people to progress on a covalent BTK inhibitor in the frontline setting.
Yeah.
And so I suppose you could conceive of the idea that a drug like Pirtobrutinib you could potentially use, especially in low risk patients. And if patients stay on drug longer, you may even see that the PFS is progression-free survival is as long as with a covalent inhibitor, or longer is what you would need.
Yeah, no, that's interesting, and I know that earlier lines of therapy trials are currently either ongoing, planned, or in development. So, as well as combinations, which of course is the logical next step, combining with venetoclax and others. So, excellent. Well, I think that probably covers the main things that we wanted to talk about. Is there anything else you want to add?
Nope, I think you covered everything.
Good. Excellent. All right. Well, thank you.